Okay, so for this next video lecture, we're going to be going over some neuroinhibition techniques, which sometimes are known as proprioceptive neuromuscular facilitation, PNF type stretching techniques, but we'll go over some of the terminology and how that might be changing. I am going to include two other research articles that we'll highlight, so if you want to get these ready, this is the Melanie Sharman PNF stretching from 2006 article, and then we're also going to go over the Weppler 2010 increasing muscle extensibility in the physical therapy journal. So to start us off with the guide on page 32, neuroinhibition stretching is the term that I'm using for this section previously, and a lot of clinicians will still use the term PNF type stretching because the roots for these techniques came from PNF strategies as it relates to some of the hold relax, contract relax, and other terminology. But as I'll mention, a lot of the words and nomenclature that is associated with these types of stretching is varied. However, in order to look at the research on this and the upcoming research that's going to be published on this, it's very important to be familiar with different terms and be able to use those terms interchangeably. In particular, we're going to focus on two of the traditional terms, reciprocal inhibition and autogenic inhibition. Even though these terms aren't being promoted as much currently, they are definitely in the literature and are definitely used clinically a lot. So I do want to go over that. Here's a quick summary about what neuromuscular inhibition stretching is. There's some type of contraction. I have isometric here. However, sometimes it's an isotonic contraction. Stretched target muscle or shortening with a concentric contraction of the opposing muscle group to lengthen the target muscle. And this is usually the distinguishing thing between PNF stretching compared to static and ballistic stretching. So one of the main differences is there's some type of contraction going on with neuromuscular inhibition or PNF type stretching. In terms of the inhibition types, there's reciprocal inhibition. And so this, let me give you this example here. If we're stretching, let's just say the biceps, so the shoulder is in an extended position. In order to stretch the biceps, while in this position, the biceps still might be contracting a little bit and trying to perform elbow and shoulder flexion to basically contract against the stretch, to not allow the biceps to be stretched. So with reciprocal inhibition, the concept is that if the triceps were to activate, so if you were to cue the patient to contract your triceps, so to ask them, try and extend your shoulder further backwards, or try and extend your elbow, lock your elbow out all the way. By locking the elbow out, by contracting the triceps, it's going to reciprocally inhibit the antagonist to that motion, which in this case would be the biceps. So agonist contraction, that would be a triceps or an elbow extension contraction, is going to relax the antagonist, which in this case would be the biceps. So that's an example of reciprocal inhibition. And this would be contrasted with autogenic inhibition. And this is a relaxation of the antagonist during the muscle contraction. So I'll give you an example that we commonly do with the hamstring stretch. So if you were to stretch the patient's right hamstring, you can see her knee is not quite fully extended, but her hip is flexed. So in this maneuver, or this theory, if the patient were to contract their hamstring, which would cause the hip to extend, the hamstrings will be contracted, 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 and then as you further go into hip flexion, because the hamstrings were just contracting, they are autogenically inhibited, and we'll talk about some of the mechanisms with this. They're autogenically inhibited to allow further hip flexion. Part of this is going to be related to the Golgi tendon organ, relaxing the antagonist muscle and increasing the range of motion. So essentially, by asking the hamstrings to contract, the target muscle or the muscle you're stretching, asking them to contract, and then relax, contract, and then relax. While they're relaxing, you get further stretch because they just contracted. So that's an autogenic contraction, or excuse me, autogenic relaxation or inhibition of the hamstring muscle, the muscle that was just asked to be contracted. So with this, you could see that there are some other terms for this. Active stretching or facilitative stretching are some nomenclatures that are used. I do want to point out that these techniques are not intended for spasticity. So if there's abnormal firing due to tone or tonicity within the nervous system, that is not one of the intentions for using these neuromuscular inhibition techniques. The terminology is going to vary greatly, so that's something to point out. Also, just as a summary of the research, there does not appear to be any consensus on whether one PNF style technique is superior to another. So with that, let's skip over this section and let's go into Sharman's article. So with this, it summarizes again autogenic and reciprocal inhibition, and it also makes a nice summary of some of the research throughout there. So I encourage you to dig into this article. I do want to basically highlight a few things that are out here. Some of the terminology in this article: target muscle is referred to as TM. Opposing muscle is referred to as OM. And then you have the musculotendinous unit, which is MTU. Okay, so with this, let me erase that. I think this is a strong point right here, that PNF, static, and ballistic stretching are all effective at enhancing joint range of motion. So all of them have been shown in the research to be effective. However, PNF stretching characteristically yields greater gains, and you can see the articles that it's referencing there. So a lot of different articles, authors are saying that you can gain more range of motion at a faster rate than you can of static stretching. So there's some good benefits to PNF stretching. We'll go down further here, some more underpinnings related to the theory behind this. Autogenic inhibition, which we went over just previously there. Some people refer to this as the inverse myotatic reflex, but autogenic inhibition seems to be the term that is commonly used for that. Some more theory on that. Once again, it relates to the GTO and the reduced motor input that the GTOs elicit an inhibition of. I do want to mention that a lot of previous research and clinical practice has been focused around this maximal contraction. Or even sometimes we use submaximal, but at a high level. So it could be 80-90% of MVIC, or maximum voluntary isometric contraction. But I do want to highlight here that, in fact, GTOs are also sensitive to very low forces. So it may not be necessary to use a high MVIC to elicit the contraction. And then conversely, you have over here reciprocal inhibition, which is the other type of inhibition. So the opposing group, the opposite or antagonist group, is going to contract to elicit the relaxation of the target muscle being stretched. So skimming through this, one of the things that's associated with this is this H reflex, or the Hoffman reflex. And there's some good studies and good research to show that this Hoffman reflex is decreased after contracting the muscle with autogenic inhibition. So that's something to know about and to be aware of, the Hoffman or H reflex. There's a little visual representation of that. And certainly there are some other mechanisms, but I want to skim basically to some of the recommendations for this article. This one is saying that just even one repetition in the research is shown to be enough in some cases. So even if you just do one repetition of a contraction and then a static stretch, which would be the PNF or neuromuscular inhibition technique, that may be enough. And then in terms of duration, there's some variability with that from one time up to 12 weeks. So there's some variability of that. Overall recommendations here. So with this, I think this is good to mention right here that in light of the findings that augmented range of motion occurs from stretching due to an altered stretch perception or tolerance. So even though there's autogenic and reciprocal inhibition, the research and what Sharman is saying here is that there's a lot of research saying that there's something important about the stretch perception or tolerance, which is why there's an increase in range of motion. We recommend that the stretch component of the PNF procedure is maintained until the sensation of the stretch abates. There's some variability as to what you do after the contraction. So you ask the reciprocal muscle to contract, or you ask the target muscle to contract, and then afterwards, do you perform a static stretch for 10 seconds or 15 seconds or 30 seconds? Sharman basically is saying here that you base it on the client or the patient and stretch it until their sensation of stretch is reached. So basically to fatigue out their ability to perceive that stretch. So I think that's a good recommendation. That's just from here. I do want to point out also here 20% is necessary, and I think they say that further. So the overall conclusion, the literature clearly supports the PNF as the most effective means to increase range of motion by way of stretching, particularly in respect to short-term gains in range of motion. There you go. So that's a nice summary from this. And then another thing that they point out here, which I think is good to say, is the appropriateness of the term PNF will be in question because of the reasons and paradigm in which this happens. It may not be due to proprioceptive neuromuscular facilitation as opposed to the stretch tolerance or stretch reflex being dampened, which is what actually seems to happen. So that is a good article to summarize this from 2006. What I want to do next is to go to Cynthia Halsman-Weppler's article in 2010. Weppler's out of Germany, and basically highlights some further information as sensory theory has been proposed, suggesting that increases in muscle extensibility are due to a modification of sensation alone. So it basically refutes some of the autogenic and reciprocal inhibition paradigms that were used previously. Also highlighting that this length in muscle length, this increased range of motion is transient, so it's temporary, which underscores the importance of what you do after the stretching, as opposed to only using stretching as an intervention. And again, like Sharman shows, a single stretching session and after short-term stretching programs are due to modified sensation. So it may only take one single stretching session to obtain results. However, it is better if you can pair that with multiple sessions in a consistent manner. Okay, so let's go further through some of the highlights of this article. In the beginning section here, there's just really a lot of background information about this, so skimming through that would be good. It defines muscle extensibility. It's the ability of a muscle to extend to a predetermined endpoint. So just imagine if you're pulling that Twizzler apart, how far can the Twizzler pull apart before breaking or tearing? So with that, that goes along with the traditional, let me scroll down here, the traditional theory about plastic region versus rupture and so forth, which is covered right here, the passive length tension curve. And so we're saying the extensibility would be how long can you pull something until you have that rupture point. But in particular, when we're stretching muscles, we're interested to know how can we obtain the plastic region, which is if we stretch a muscle, let me go back here. If we stretch a muscle and then we relax and then we go to measure range of motion or take it again, if it's in this elastic limit, the range of motion after the stretch as compared to before the stretch is going to be identical. Whereas if we can go into the plastic region, there are going to be gains of motion and extensibility afterwards, even if temporary or transient, afterwards as to before. So often we're trying to get into this plastic region. However, you can probably imagine that sometimes being in this plastic region is going to stimulate mechanoreceptors, pain fibers, and other things, so it may be uncomfortable or not so much pleasant for the patient to receive this stretch. And sometimes patients can do this themselves, or clinicians can do this where they take this too far, not quite to rupturing, but they can go deep into the plastic region, which can be painful. And although they gain range of motion, they do elicit pain, and there may be some microtrauma associated with that as well. So I'm going to go back one page to 442 on this, and to highlight the viscoelastic stress relaxation. Imagine if you take a hamstring or another muscle and you stretch it. The time is in seconds here. So you'll probably notice that if you stretch a muscle 20, 30, 40 seconds into the stretch, you'll notice that the patient or the client, the individual you're stretching, they don't basically resist that stretch as much as you get further into this time. So it requires less torque or force that you're counter pressuring against or resisting against, because the stretch tolerance is decreased. So you notice if you stretch a patient's hamstring or calf or other muscle, you notice that basically when you initially start to stretch, you feel that resistance, and then over time they're going to accommodate to that stretch, and they're going to give you less and less force against that stretch or the counter pressure against you. And that's what refers to these viscoelastic stress relaxation during a static stretch, which also applies to neuroinhibition or PNF stretching. So we'll go further down here a little bit. There's definitely conflicting interpretations, conflicting terminology. That's definitely true throughout multiple, so it is confusing to look at different research, which is why you have to be a little familiar with multiple nomenclatures and vernaculars with this. There's also conflicting results, but there is a growing evidence to support the theory that increases in muscle extensibility observed after stretching are due to a modified sensation only, as opposed to some of the autogenic and reciprocal inhibition type theories. With this, I'll scroll down really to the end to say that there's also variability in the terms that we use with our patients and how do we describe what a stretch should feel like. Should it feel like resistance, stretch, discomfort, tightness, stiffness, pain? There's some altered perceptions of what that is. Scrolling down further, getting to the conclusion of this. A growing body of research refutes these mechanical theories, suggesting that instead subjects who are asymptomatic, increases in their muscle extensibility observed immediately after stretching are predominantly due to a modification in subject's sensation. So their lack of sensation or their decreased perception of that stretch and increased tolerance to the stretch are why they have increases in range of motion. So with that, we'll go back to the guide to highlight. This is Philip Page's research. I think this was 2011 or 2012, maybe. But I do like this table here, looking at some different comparisons. So what you're looking at here is, oops, let me go back to here. So you're looking at range of motion and how does it change? Does it increase? Let me just zoom in a little bit on this. Does the range of motion increase or does it decrease with static stretching, or is there no significant difference between static and dynamic. You can see only one study here showed that range of motion is going to be better with static when compared to dynamic. However, what happens when you compare pre-contraction, or what a lot of people would say PNF stretching, as compared to dynamic or static stretching? And what you see here, that's no significant difference here, right there. So these authors found, so if you look at all these authors, they found essentially there was not any significant difference between pre-contraction stretching and static stretching. Whereas these authors here found that pre-contraction stretching, PNF stretching, neuroinhibition stretching, was actually better than some type of static stretching. So you can see there's conflicting results. And I like what Paige is saying here as the overall recommendation. Static, dynamic, and pre-contraction stretching are all effective. So they're all effective methods of increasing flexibility and muscle extensibility. However, these modes may be more effective in specific populations, which you'd have to determine. Several authors have noted that individualized response to stretching. Therefore, stretching programs may need to be individualized. So essentially it's saying there is the element of patient-centered care in terms of determining what the patient believes they will benefit from. The research is saying is that multiple things can be beneficial, and then tying together the clinician's perception of what might be beneficial. So stretching needs to be individualized. However, I would also highlight, though, there's significant research to say that PNF is going to be more effective than static, and there's also research to say that there's no significant difference. But there isn't necessarily research to say that static is going to be better than PNF. There's just research to say that it may be the same as PNF. So all in all, I still think this research favors PNF stretching. So you can see that these showed that it was better, these showed that it was equal, and there really wasn't much to show that static was better. Let me just go back here, and then that's pages, and then you have some other research which I've highlighted here, going back to the intensity or the percentage of MVIC. You can see that you probably don't need to go close to 100%, 20 or 60% may be sufficient. Here's some specific ways they tested it using popliteal angle. Contract, relax, gained 11 degrees. Contract, relax, agonist contract, gained 15 degrees. And there's some further videos that highlight what exactly these techniques are. A Law study in 2009, stretch tolerance, again, what Weppler was showing there. H reflexes, which have been studied for quite some time. Even this study, I highlight this one from 1991 to show that this has been researched for quite a long time. They looked at ankle plantar flexion, contraction to elicit a greater dorsiflexion or gastroc and soleus stretch. And you can see that they were depressed really significantly, 83%, just within 1/10 to 1 second. More recent research, or sorry, another research in 87, not more recent, but 87 research showed that they were significantly smaller as well. So what I have here, I think will be really important, a nice summary of what the research says about this. I think 20% MVIC is a sufficient amount to elicit a contraction of the muscle and to cause the necessary inhibition or relaxation or change in stretch tolerance. It does seem to be at least 15 seconds for the static phase is necessary, although Sharman says maybe you should go up until the stretch abates, which could be 15 seconds, it could be 20, it could be 30. It depends on what the patient perceives with that. However, for the GTO contraction, it does seem to be important to get at least a 6-second contraction. So I think that's some highlighting. And then recommendation also to apply the stretch quickly. Because you want to take advantage of the change in H reflexes, applying the stretch quickly is going to elicit the best results. So as soon as they contract and then relax, you're going to immediately go into the static stretch. So that's a quick summary of what neuroinhibition stretching theory and paradigm research says about the theory, and hopefully that summarized it. Certainly more practice and experimentation is needed on this with your patients and clients and other classmates, but I hope that was a good summary. Thank you very much, and I'll see you for the next online lecture.